Well, welcome back to the lower half of our lecture, the lower GI tract. So we've covered the upper GI tract, which basically starts at the oral cavity, the mouth, and ends at the stomach, and a location called the duodenum. And you see that listed in the small intestine here. And then we're going to break down some of the components of the lower GI tract. The upper GI tract is about breaking food down, preparing it for absorption. The lower GI tract is about, first of all, absorbing the nutrition, which happens in the small intestine, specifically in the duodenum, the jejunum, and the ileum. And then it gets passed through onto the large intestine, known as the colon. And here you have the cecum, and that's where the cecum is the point where the ileum, the small intestine, and the large intestine meet. And that's where we find the appendix as well. And of course, then we have the ascending, transverse, descending sigmoid colon, the rectum, and the anus. So those are the structures we'll be talking about. As I said, most of the absorption of nutrition happens in the lower GI tract, and so that's kind of what we're going to be talking about. It used to be, once upon a time, we broke all these 3 sections of the small intestine down. You will do that when you go to physio and anatomy. You'll learn the parts of the small intestine more intimately than we'll teach you here. What you need to know for our purposes is that it's in 3 sections. The first section is called the duodenum. Or if you know someone who went to school on the East Coast, they're going to say duodenum. Duodenum, I've also heard before. I was always taught duodenum. So you choose from those 3 pronunciations. All are correct as far as I can tell. Jejunum is the second part. That's the biggest part of the small intestine. And the ileum is a shorter part at the end of the small intestine that connects to the cecum and then to the large intestine. So what's going on in the small intestine is this chyme that's been created in the stomach is now being passed through via peristaltic contractions, and the nutrition is being absorbed, along with water and other things. The small intestine, the entire tract, is lined with villi. These are tiny finger-like projections that enable the small intestine to absorb nutrition from food. So you see these finger-like projections. They're projecting towards the center of this tube, this small intestine that we're talking about. What are they doing? They're absorbing the nutrients from food. They're absorbing water, so they're getting the actual nutrition our body needs. They're able to ferret it out and pass the rest down the line as just waste product. And the thing that's cool about the villi, is they increase the surface area by which the small intestine can absorb nutrition. So the villi can absorb on any one of the sides of these protrusions. And of course, if you take this and compare it to just a tube of the same length without villi, you're going to have much more absorbent surface with the villi. So it's a great design for the body to be able to collect all that nutrition, all the vitamins, minerals, and everything your body needs to survive. And so it's through that process, and it happens in the small intestine. Now, we have another combining form, entero, which means intestine. And really the distinction here, we often think of the intestine as being the large and small intestine together, and they kind of are. But we often, in fact, typically, and I'm thinking here almost always, when we talk about the large intestine, we say colon. When doctors refer to the intestine, they're usually talking about the small intestine. In other words, the duodenum, jejunum, and ileum together. So that's generally how I've seen it used. So entero is that combining form for intestine. Enteric means pertaining to the intestine. Enteropathy is a disease of the intestine. Enteritis is inflammation of the intestine. And enterectomy would be an excision of the intestine. Going back to the top of that list, enteric, we see some aspirin here at the bottom of the page that is enteric coated, you'll see on the label, which means it's very well coated, and it's coated to the point where it can make it through the stomach intact, and it will then break down and dissolve in the small intestine. So I don't know if you've ever paid attention to dosages of medication, but 75 milligrams for aspirin is an abnormal aspirin dose. Usually it's 61 milligrams, or it goes up into the 130s. 75 is an odd dose, but these are enteric coated, and they're actually used to create a form of enteritis known as Crohn's disease. So this type of tablet will pass through the stomach. It will make it to the small intestine. It will then dissolve in the small intestine, and there it's therapeutic. If the aspirin were to dissolve in the stomach before it got to the small intestine, it would not have the anti-inflammatory qualities that we want it to have. Hence the term enteric, pertaining to the intestine. And here we go. So we have gastro for the stomach, entero for the intestine. Gastroenteritis, inflammation of the stomach and the intestine. It's often called stomach flu. There is really technically nothing called stomach flu. It's usually gastroenteritis. It means we've eaten a bacteria in some food that didn't agree with us, or we've eaten something that's really upset our stomach. And, usually you feel nauseated, lethargic. It's just, crampy and that really rotten feeling in your stomach when you're sick. And it's no fun to have. So you might come to us and say, or a patient might come to you and say, I've got the stomach flu. And secretly you're going to know inside, when you think about it, that they have gastroenteritis. And the most common one is something called AGE, which stands for acute gastroenteritis. And you will see this in clinical and emergency medicine a lot. Okay, so we have a procedure here called an EGD. This is an esophagogastroduodenoscopy. I'll try it again, esophagogastroduodenoscopy. Not everybody wants to say all those letters all at once, so they say EGD, and we all go, yep, we know what they're talking about. This is a visual examination of the esophagus, the stomach, and the duodenum using a scope. So they can't go all the way into the small intestine with the scope, but they can get into the duodenum, which is around 7 or 8 inches long. And for any sort of stomach ailment and upper intestinal ailment, a scope like this can be very beneficial. Not always the most pleasant thing, but they use micro cables now. They're in the form of fiber optics, and it goes down your throat, and it's a lot better than the old school where they had something, it was about twice the size of a pencil circumference, and you would put that down your esophagus. And I'd seen patients get it before, and it didn't look like they were enjoying it. This one, this new fiber optic system they use is a lot more user-friendly, I guess, to be the way to put it. Okay, so that's all you really need to know about the small intestine as far as med term goes. Now we're going to take a look at the colon, in other words, the large intestine. So once again, those parts are the cecum, the ascending, transverse, descending, and sigmoid colon. And we're going to look at those we'll take a little look at each of those. Here's a fun word for you, Borborygmus, and its plural is Borborygmi. It's a rumbling or gurgling noise made by the movement of fluid or gas through the intestines, usually through the large intestine. Why? Because the large intestine is now getting this chyme that came from the stomach and went through the small intestine. The small intestine, remember, there's peristaltic contractions going all the time. So they're constantly squeezing the water out, and it's becoming it's becoming less like chyme and more like stool as it passes through the small intestine. By the time it gets to the large intestine, it is actually transformed into stool for the most part. Sometimes air gets trapped in there, and that growling or gurgling sound in the stomach, usually associated with a lower GI pathology that might be causing diarrhea, for instance, the sound was associated with it. Borborygmus. So there, that's kind of an off the wall word for you, but now you know it, so you can win that night at trivia when that card comes up and it says, so what's a rumbling or gurgling noise that happens in the intestine? You can go, Borborygmus. I learned that in med term. Okay, continuing on with that large intestine or that colon, we have a combining form here, Colo for colon. Colonic means pertaining to the colon. Colitis is inflammation of the colon, and colectomy is excision of the colon. Inflammation happens anywhere in our body. If it happens in the colon, and if it happens similar to those GERD symptoms I mentioned earlier, you can get erosive colitis, which is also as dangerous and as unpleasant as ulcerative esophagitis. So inflammation in the colon, no bueno. We want to avoid that as much as possible. And if any occurs, of course, you'll be symptomatic and hopefully report that to your doctor, or you'll recognize those symptoms in your patient and understand that the colitis is something they may be suffering from. Another form, or another use for the combining form Colo for colon is colostomy. We attach it to stomy, which means forming a new opening. So a colostomy is literally forming a new opening in the colon. You see an example of a before and after. So the before, the entire colon's intact. The after, probably a case of colon cancer or, once again, erosive colitis. So part of that colon had to be removed. And so what they do to replace it, because one has to defecate, because you have to eat, is they bring that section of the colon up to the surface. And over on the left, you'll see something that's labeled stoma. And that's exactly what it is. And that's pretty close to what they look like. I've seen them many times. They bring the intestine right to the surface. They attach a bag to it. And then fecal matter, instead of going the normal route through the sigmoid colon, rectum, and anus will then terminate in that descending colon right there, and the feces will be pushed out into the bag via peristaltic contractions. These can be used short-term, they can be long-term. If there's permanent damage to the colon and there's no hope to recover or resect it, then they're just going to say, well, it's a colostomy now from here on out. However, to my surprise, as a rad tech student, I did learn that patients would come in and they've had a colostomy in place for 6 or 8 months. And now whatever they were trying to heal has healed, and they're coming in and we're doing x-rays because they're about to have their colostomy reversed and their colon reassembled. So it doesn't always mean it's permanent, but it's a bit of a job to manage, and it can be a little tricky, but most patients manage it very, very well. If you ever encounter one and you're not so sure what the protocol is, ask the patient. I haven't seen a patient yet with a colostomy that couldn't tell me exactly how we should care for it. So it doesn't hurt. We don't know it all in medicine. We just know what we know, and we learn new stuff every day. A different combining form for colon is colono, as in colonoscope. This is a visual examination of the colon. A colonoscope is the instrument for viewing the colon. The procedure is called a colonoscopy, a visual examination of the colon, something everyone should get done over the age of 40. In the last several years, probably the last 10 or 15 years, there has been a rise and increase of colon cancer in people in their 20s. And before, it was never seen that young. Usually they would perform colonoscopies at age 50 and older. Since then, my understanding is the protocol has shifted down to they recommend your first colonoscopy at 40. I had a colonoscopy at age 30 because my mother died of colon cancer. Unfortunately, they found cancerous polyps, but fortunately, they removed those polyps, and I'm free of any risk of colon cancer right now. In the future, that may change. So colonoscopy, if you have a first-degree relative who's had colon cancer, highly advised to get it done, and probably sooner the better. The downside is insurance won't always pay for it if you're under a certain age. So that's just one of the trappings of our medical industry. So we have different parts of the colon. I mentioned ascending. That's the first part of the colon as it rises up. That's on the right side of the body. The transverse colon goes all the way across, so that's that part that reaches across. And then the descending colon is the one that comes down and then ends in the rectum and the anus. And if you want reference on that, you can flip back to one of our previous slides, and you can see it sitting up. Here it's to the side. This patient is in what we call a decubitus position. So the colon is tipped to the side, but the parts are still the same. That one that's going across the right side as the patient's decubitus position here, that's the ascending. Transverse is that long one where you see the mark says colon, and descending is the other side. The very bottom of the descending colon is called the sigmoid colon. Sigmoido is how we use the combining form. A sigmoidoscopy is like a colonoscopy, but it only goes as far as the sigmoid colon, and a sigmoidoscope is used for that procedure. They're not done that often anymore unless the doctor is certain that the pathology is in the sigmoid only. And if they're certain of it, then they may just do a sigmoidoscope. But often they will do a full colonoscopy to make sure they don't miss anything. And I had mentioned earlier that you have a place called the cecum. There, once again, is an illustration of the intestine. So very quickly, the cecum is right here. We have the ascending colon, transverse, descending colon, sigmoid colon, rectum, and anus. So just to clarify that, there's a drawing, so I had a chance to tell you. The real thing I wanted to get to here is a small appendage that's attached to the cecum. It's called the appendix. Appendo or appendiso, either are appropriate to describe it. You can mix and match. Appendicitis is inflammation of the appendix, and an appendectomy is excision of the appendix. Maybe some of you have had this surgery. They usually do it laparoscopically, like I illustrated earlier. And notice the difference in pronunciation. Now, the top word is appendicitis, but it's appendectomy. So the accent changes slightly between those two different words. And so they just go in, this appendix will become inflamed. It doesn't really have a digestive function anymore. However, if it becomes inflamed and bursts, then you have an intra-abdominal infection, which is very risky. And you don't want that to happen. So if it becomes inflamed, and this is going to be right lower quadrant pain, the surgeon is going to come in and remove it before it becomes a risk to you. And with that note, we're going to go ahead and hold right there. I've got one more part to introduce to you in the next section, and then we'll be through with this lecture. So I'll be back with you in just a few moments. Thank you.